Unit 2 will begin with Chapter 17, which is the pelvic girdle. Unit 2 consists of the pelvic girdle, the hip, and the knee, which is respectively Chapters 17, 18, and 19. Unit 2 will begin with the importance that students not only memorize bones and the landmarks, muscles, where they originate, insert, and what they do, but also how to locate and palpate these landmarks and the muscles on an actual person. To locate bony landmarks, muscle, students will need to practice on yourself and on someone else. I would go as far as to practice on different body types as well as males and females, as this is what you would see in the clinic every day. We use this in to gather data collection, to help treat, to educate our patients, and to assess if certain specific exercises or activities are actually working what we want to work. So this is a very important skill that we use as PTAs. So the structure and the function of the pelvic girdle consists of 4 bones: sacrum, coccyx, and 2 pelvic or hip bones, each with an ilium, ischium, and pubis. The pelvis supports the weight of the body through the vertebral column and passes the force onto the innominate or hip bones via the sacrum. So this is how, when you are standing and weight is going through your body, this is how the weight is transferred into your legs. Joints or articulations of the pelvic girdle include this lumbosacral joint, the sacroiliac joint, which you will also hear as SI joint, and the symphysis pubis or pubic symphysis. Please note how each joint is described here, and you can reference that in the book as well. These are the difference between the male and female pelvis. As you can see, the male pelvis is much narrower, 90 degrees or less, whereas the female pelvis is 100 degrees or more, so a lot wider. This is because women go through childbirth, and this is how the canal opens to deliver baby. So we're going to start with the sacroiliac joint. So this is the structure and the function. It's a synovial, non-axial plane joint. There's no voluntary motion of this joint, meaning you can't move it by yourself on your own. And it has a fibrous capsule reinforced by ligaments. It is built to be very strong, to lock surfaces together. The function of the SI joint is, like we said before, it transmits weight from the upper body through the vertebral column and into the hip bones. It's designed for the stability, not mobility, only allowing about 2 to 3 millimeters of motion. This is actually widely debated among researchers, therapists, physicians, etc. And we will talk about this in detail, be it in class or online with your teacher. So here are bones and landmarks of the sacrum. The sacrum is a wedge-shaped bone. It's got 5 fused sacral vertebrae. It articulates with the last lumbar vertebrae, or L5, at an angle called the lumbosacral angle, which we will talk in detail in a minute. But the landmarks are the body, the articular surface of the SI joint, the pelvic surface, and the coccyx. Here's a different view of the sacrum as well. So notice all the bony landmarks, and please remember these for different quizzes and exams. Here's a greater picture of the pelvic girdle. And these are some of the pelvic girdle bony landmarks that you will need to know and memorize for exams. You can use the picture on page 285 to help you identify the following list here. Note the different attachments for different ligaments and muscles, as you can see on the screen here. Here are some other pelvic girdle bony landmarks. We will talk about, or you can feel the ischial tuberosity when you are sitting, As if you want to, you sit in a chair, place your hands between the chair and your bottom, first when you slouch, and then sit up. When you sit up, you should feel the ischial tuberosity rub across your hand, in between the hand and the chair, and it should move there. Alright, so here are the sacroiliac joint ligaments. These are very necessary for stability, given that we put a lot of weight through the body and into the hip joints. So these ligaments are broad, most of them are broad, and necessary for stability to keep our pelvis in check. You need to know the location of each of these ligaments on this screen, as it will be important to identify them on different exams and quizzes. And note that the picture here you see is an anterior view. Alright, next slide here is the interosseous sacroiliac ligament. It's the deepest, shortest, and strongest of these ligaments. And it fills in the roughened area immediately above and behind the auricular surfaces and the anterior sacroiliac ligament. This connects the tuberosity of the ilium to the sacrum. Next is the posterior sacroiliac ligament. It is two different parts. There is a short one and a long one. But you need to note the differences between the two. The short posterior SI ligament prevents forward movement of the sacrum, while the long one prevents downward movement. Also note that this picture is a posterior view. Next is the sacrotuberous ligament. It is a strong triangular shaped ligament that runs between the PSIS and PIIS and the posterior and lateral side of the sacrum, inferior to the auricular surface. It serves as an attachment for the gluteus maximus and prevents forward rotation of the sacrum. The sacrospinous ligament is triangular shaped as well. It's deep to the sacrotuberous ligament and has different broad attachments. This and the sacrotuberous ligament convert to the greater sciatic notch into a foramen, and this is where the sciatic nerve passes through. Also note that this is now another anterior view. The pubic symphysis is located in the midline of the body. It's where the right and left pubic bones are joined on the anterior surface, and it is the amphiarthrodal joint with a fibrocartilage disc. So we're going to be looking at this section here, the landmarks of the pubis. So if you'll pay attention to kind of the front area here, this is a right medial view, or a medial view of the right pelvis, excuse me. And you need to know these landmarks that you see on the screen here. Alright, next we're going to talk about what's called the lumbosacral angle. We mentioned it before, but it's formed by drawing one line parallel to the ground and another line along the base of the sacrum. The angle increases if the pelvis tilts anteriorly, and the angle decreases if the pelvis tilts posteriorly. We will talk about those two, an anterior pelvic tilt, posterior pelvic tilt, in greater detail in just a few minutes. But know that the optimal angle of the lumbosacral angle is 30 degrees. So the lumbosacral angle is associated with different pelvic girdle motions, but also the hip joint as well. So the spine is connected to the pelvis via the lumbosacral joint, and that's where the lumbar vertebrae articulates with the sacrum. The sacrum is part of the pelvic girdle. So when the pelvic girdle moves, it causes changes in the lower spine, specifically in the lumbar region. It also changes the lumbosacral angle. In addition, because the head of the femur fits into the acetabulum of the pelvic girdle, when the pelvic girdle moves, it not only affects the lumbar spine, but also the hip joint. So first up, we're going to talk about lumbar lordosis. Lumbar lordosis equals lumbar extension. Remember that. So to kind of feel this, we've already done this activity, but we're going to try it again and think of it a different approach here. So sitting in a chair with the palm of your hand on your low back, first I want you to slouch. When you slouch, your lumbar spine or your lower spine curves outward, putting your hand more posterior. So you should feel your spine come against your hand more. Now I want you to sit up straight. When you sit up straight, you should feel like the lower part of your back moves anterior, or that curve increases. When your lower spine, or your lumbar spine, moves anterior and there is a concave curvature or more of a curve in your low back, it is called lumbar lordosis. And this is kind of what it looks like if you look at the picture on your right here. Lumbar lordosis, or increased lumbar lordosis, correlates with an increased lumbosacral angle. This can cause shearing stresses of L5 on L1 to increase. So if you look here, L5 sitting L1 kind of increases, meaning that the shear force coming down this way can make a big difference here. Now this is prevented by ligaments and the shape and the fit of inferior articular processes of L5 inside and superior articular processes of S1 behind. So ligaments help to prevent this, as well as bone shape. Excessive part of this is what we call spondylolisthesis. That is where L5 or any of the lumbar vertebrae actually slip forward too much on S1 or other associated lumbar vertebrae. So when we decrease this, so decreased lumbar lordosis correlates with an angle decrease. So that means the posterior aspect of the spine is flattened, or it moves posteriorly. So this would be like when you slouch. As you can tell from the picture on the bottom right here, this is when this ASIS moves behind the pubic symphysis. We'll talk about that more in detail in just a second. So these pelvic girdle movements that we're talking about are movements in the sagittal plane here. Okay, so sitting again with your hand on your low back, slouch again so you feel the low back flat. Okay, this is when when it moves posterior, it's also called lumbar flexion. So when you flatten your back out or you slouch, your lumbar spine is in what we call lumbar flexion. The pelvic girdle moves posterior also because the lower spine attaches to the sacrum, which articulates with the ilium via the SI joint. So you can't move one without causing to move the other. When you slouch and your low back flattens, you have decreased lumbar lordosis, also known as lumbar flexion. When the lumbar spine flexes, the pelvic girdle moves posteriorly. That means in the sagittal plane, pelvic girdle motions that occur are an anterior pelvic tilt or a posterior pelvic tilt. To determine if the pelvic girdle is anteriorly or posteriorly tilted, we use bony landmarks. Usually the ones that we use are the ASIS and the pubic symphysis. So if a person is standing in the anatomical position, the pelvic girdle should be in the neutral position. So neutral position is when the ASIS of the pelvic girdle in direct alignment, superior and vertical alignment with the pubic symphysis, as you can see on the screen here by the two arrows. This gives you the optimal lumbosacral angle, which is, again, 30 degrees. When the ASIS moves anteriorly to the pubic symphysis, it is what we call an anterior tilt, as you can see by the picture here. When the pelvic girdle is in an anterior tilt, the lumbar spine moves anterior as well, which increases the lumbosacral angle. This is what is called lumbar extension or hyperextension. In this case, the hip moves more toward flexion with an anterior pelvic tilt. So random quick question here. If you're sitting up straight, then you move your pelvis forward so the ASIS moves anterior to the pubic symphysis. What motion occurs at the lumbar spine and what motion occurs at the hip? The answer is your lumbar spine should go into extension or hyperextension, and your hip actually moves more towards into flexion, as you can tell by the picture here. So with an anterior pelvic tilt, what muscles move your pelvis anteriorly? At the trunk and at the hip. Now, we will go into trunk and hip musculature later on. So for now, what you're going to see us use are these broad terms. For example, if the question is what muscles act to form a force couple to move your pelvis anteriorly, at the trunk we're going to right now say trunk extensors. In detail, we're going to go to erector spinae, but that will be later in Unit 3. For now, at the hip, we're going to say hip flexors. In just a little while, or in the next couple chapters, we're going to learn that that's the iliopsoas muscle. So now let's look at a posterior pelvic tilt. So a posterior pelvic tilt is when the ASIS moves posteriorly to the pubic symphysis. When the pelvic girdle is in a posterior tilt, the lumbar spine then moves posterior as well, which decreases the lumbosacral angle, meaning that the lumbar spine is now in lumbar flexion, as you can see on the screen here. So in the sitting position, now let your pelvis rotate posteriorly so that the ASIS moves posteriorly to the pubic symphysis. What motion occurs at the lumbar spine, and what motion occurs at the hip? The answer is that a posterior pelvic tilt results in lumbar flexion or decreased lordosis and movement at the hip toward hip extension. What muscle groups act to form a force couple to help perform the posterior pelvic tilt? At the lumbar spine, it's going to be the lumbar trunk flexors or your abdominals, and for the hip, it's the hip extensors, or right now, glute max. So here's a nice picture and detail to kind of show each of the different pelvic girdle motions in the sagittal plane. So for picture A, you're going to see that that is a neutral, normal lumbar spine, and the hip is neutral as well. B is an anterior pelvic tilt, which increases lumbar lordosis and the hip moves into flexion. And C is a posterior pelvic tilt, which is decreased lumbar lordosis and the hip moves into extension. Okay, so that was kind of more of a look at how the lumbar spine moves. Now we'll talk a little bit more about how the femur moves and what happens at the hip. So if you sit with a normal spine alignment, just sit nice and tall, kind of neutral. Now when you slouch or you do a posterior pelvic tilt, what happens at the hip? The angle decreases and it moves towards hip extension. Now sit up as straight as you can and tilt your pelvis anteriorly. SIS moves anterior to the pubic symphysis and an arch in your lower back, meaning that your hip is moved more into flexion. So this kind of talks a little bit, this picture is about the same picture, but it talks a little bit more about what happens at the hip. So make sure you know the differences of what happens in the lumbar spine and in the hip during an anterior and posterior pelvic tilt. So kind of recap what a force couple is. I know we learned this in Unit 1, but a force couple is when opposing muscle groups create the same movement or same type of movement. So if you have one hand on each side of a steering wheel of a car and you decide to turn right, the right hand moves down while the left hand moves up, so that the motions occur right, down, left, up, moving in opposite directions, but they create the same motion, which is to turn the steering wheel right. Force couple is like the steering wheel scenario. The muscles on the anterior aspect of the body is pulling the anterior pelvis down, while the muscles on the back body are pulling the posterior pelvis up. Then you have an anterior pelvic tilt using a force couple. This is what it looks like. Excuse me. So the lumbar trunk extensors, when the erector spinae muscles contract, they cause lumbar hyperextension, which pulls the pelvis up posteriorly, resulting in an anterior pelvic tilt. The hip flexors contract, so they pull the anterior pelvis down, so that results in an anterior pelvic tilt as well. When they work together to cause an anterior pelvic tilt, they are working as a force couple. Vice versa, when the trunk flexors or the abdominal muscles work along with the hip extensors, you will get what's called a posterior pelvic tilt. Okay, so we've covered motions that occur in the sagittal plane of the pelvis, so now we're going to talk about what happens in the frontal plane. In the frontal plane, when standing in anatomical position, the iliac crest and anterior superior iliac spines should be level, as seen on the picture here. However, when they are not level, that is when we get what's called a lateral pelvic tilt. And this occurs when two iliac crests are not level because the pelvis moves as a unit, one side up and the other side down. So here's a little activity for you. First, stand up in anatomical position. Place your hands on your iliac crest, right hand on right iliac crest and left hand on left. Third, lift your left leg so you are now just standing on your right leg. Let the left side of your pelvis drop down as you let your right hip move laterally. And this is what is called a lateral pelvic tilt. So it should have looked something like that right there. Good thing to know is the point of reference here. This is very, very important. And this will show up on your quizzes and exams. The side that is unsupported is the point of reference. Now keep in mind the picture you're looking here is from an anterior view. In this case, this is what is called a left lateral pelvic tilt because the left side is unsupported in this picture. So to control or limit the amount of lateral tilting, opposite muscle groups work as a force couple. So we have another force couple going on here. Now this one is in the frontal plane. They work in what's called a reversal of muscle function or reversal of muscle action. So to keep the pelvis fairly level, left trunk lateral benders pull the pelvis up on the left side, and hip abductors pull the pelvis down on the right side. With this motion, you'll have what's called associated motions with this. So in the picture, the supported side or the right side actually moves into right hip adduction as the pelvic tilts down on the left. That means the right hip becomes closer to the midline, thus we get right hip adduction. The left hip technically then abducts. Since the pelvis tilts down on the left hip angle is now further away from the midline. Therefore, it is moved into hip abduction. And in this case, usually the trunk side bends to the right to compensate. So, word to note here, realize that even if the hip joints or the legs don't look abducted or adducted, it is the pelvis that moved and changed the angle of the hip joint with the midline of the body. When you look at the tip of the triangle that represents the center of the pelvic girdle, it has moved to the right. So the right leg didn't adduct necessarily, but the midline of the pelvis is the thing that shifted towards the right leg, meaning that it made it look, or it made it into right hip adduction. Know that there are two, let's go back to this picture a minute. So know that there are two components here when this moves. So we would normally see right hip adduction as this swinging out. However, because it's a joint, it's two parts. Instead of moving the leg, we move the pelvis, and that is what is shifting this into right hip adduction. Alright, so now we're going to talk about pelvic girdle motion in the transverse plane. So this is to do with rotation. So in a vertical plane, anterior superior iliac spine should be aligned, as you see in the first picture here. Rotation occurs when one side moves forward or backward in relation to the other side. So here we go in picture A. You have left forward rotation of the pelvis, so the trunk rotates to the opposite side, and you have right hip internal rotation because you can see that the angle increases in here. B is just neutral position, and then C is left backward rotation of the pelvis. So remember, the unsupported side is the point of reference here. And just to kind of review associated motions of the pelvic girdle and vertebral column and hip joints, please look at and memorize table 17.1, which is on page 290 in your textbook.